Okay, we'll go ahead and get started. For those of you who don't know me, I'm Kyle Grose. I'm one of the PGY1 pharmacy residents, and I'm really committed to stay on in oncology next year. First of all, I have nothing to disclose, and I also want to give a little bit of background as to why I chose this topic. One, obviously I'm interested in oncology. Two, I think that supportive care is one of the main areas that pharmacists can have an impactful part of the patient care. And then also because I noticed since starting my residency that a lot of our oncology patients were receiving apixaban for anticoagulation. And though I knew from my student rotations that low molecular weight heparin was the first-line agent, the preferred agent for these patients, kind of wanted to go into it and look into it a little bit more, see why are we doing this at UVA? Are we doing something wrong, or is this something cutting edge that we're just ahead of the game on? So the objectives for this presentation are to explain the pathophysiologic changes that lead to a hypercoagulable state in the oncology patient population, identify the current guideline recommendations for treating venous thromboembolism in cancer patients, and to evaluate the use of direct oral anticoagulants and their future place in this patient population. So we'll start off with a little bit of background. Patients with malignancies, it's a pretty well-known fact that they're at an increased risk for experiencing a VTE. And in fact, cancer has been determined to be an independent risk factor for developing a thrombus. And in one study that I looked at that included ambulatory care patients with solid-state tumors, it was defined that VTE was the second leading cause of death in these patients, secondary to their malignancy itself. In one study that included ambulatory high-risk cancer patients, those patients developed a VTE in 12.4% of the time, 12.6% of the time, versus their non-cancerous comparators who developed a clot only 1.4%. And there are processes that lead to the increased risk. It's multifactorial. There's both intrinsic and extrinsic factors that cause the pathophysiologic changes that lead to this hypercoagulable state. So a thrombus, the pathophysiology behind any thrombus can really be defined by the Virchow's triad, which includes blood stasis, endothelial injury, and hypercoagulability. Now, looking at it from a cancer patient-specific perspective, you can see that blood stasis is most often caused by immobility. These patients have a poor performance status, and they're not up and ambulating as much as we like them to. Also, from direct tumor burden that presses onto a vessel causing blood stasis or occludes blood flow altogether. For endothelial injury, we have cancer agents that are being administered that are often detrimental to the endothelium in the blood vessel itself. And we introduced central venous catheters to administer these agents, so we're putting a foreign object into their blood vessel directly. And also the direct invasion of cancer cells into the endothelium. Now, the hypercoagulable state can be caused by the release of the procoagulant factors directly released from the cancer cell itself. So this triad can further be explained, though, by intrinsic and extrinsic factors. So looking directly at the intrinsic factors that are caused by the tumor cell itself, we have the production of procoagulants such as tissue factor and fibrinolytic activities that lead to direct clotting cascade activation. Tumor cells themselves can express adhesion receptors along with the release of cytokines and angiogenic factors that altogether cause the activation of host cell procoagulant and proadhesive cells, including endothelial receptors and platelets, leukocytes. And this meets a common pathway with thrombin and fibrin formation, ultimately overall causing this hypercoagulable state in patients. Now looking at this first step, the production of procoagulant and fibrinolytic activities, really, tissue factor is the main overall factor that causes the procoagulant effects, which is the physiologic initiator of coagulation. It localizes factor 7 and 7A onto the endothelial cell, starting off the clotting cascade. Normally, it's under strict control. In patients, they don't even express tissue factor until a pro-inflammatory cytokine such as TNF and interleukin are released, upregulating its presence. But in cancers, it's upregulated by oncogenes such as KRAS or KRAS, and also tumor suppressor genes such as TP53. These genes upregulate it in cancer patients. Now, certain cancers are also more likely to have an increased amount of it. Pancreatic and brain cancers are known for having the most amount, whereas breast cancer has quite a bit less comparatively. Microparticles, selectins, and leptin, together, they also play a role in the important part of the intrinsic pathway. Microparticles and selectin, they create this groundwork for developing leptin, and leptin then has been shown to upregulate tissue factor as well, so it's kind of this cycle altogether. And overall, the ones I just talked about, these are the main intrinsic factors that lead to this prothrombotic state. And now we'll talk a little bit more about the extrinsic factors. So alterations of blood flow, blood vessel compression due to advanced tumor burden. An extreme example of this would be when a tumor itself presses onto the superior vena cava and occludes blood flow itself, or causes a clot to be formed to occlude blood flow. And then, so basically what you get is the blood from above the heart is not allowed to go back down to the body into circulation, so you get this extreme just blood holding onto the top of the half of the body. And that is more of an extreme example of a tumor pressing onto a blood vessel. Then you also have central venous catheters. Actually, I have a picture of superior vena cava syndrome. And you can see that the blood is definitely held up above the heart. And then central venous catheters, these are being placed into these patients so we can administer the chemotherapy agents. But anytime you place a foreign body into the blood vessel, you're basically just giving them a breeding ground for a clot to start. And immobilization, again, these patients have a more poor performance status, and they're not going to be up ambulating as much as a normal person would be. Then we also have alterations to the vasculature epithelium. And this is, again, like I talked about, medications being administered. You have anti-neoplastic, anti-angiogenic medications. Surgery itself, anytime you're creating damage onto a blood vessel, you're creating the grounds for a clot. And then, again, the direct tumor invasion of the cells being placed into the epithelium. All right, so this leads us to question number 1. Which of the following is not an extrinsic factor that leads to an increased risk of venous thromboembolism in patients with a malignancy? Blood vessel expression of tumor factor, exposure to anti-angiogenic agents for cancer treatment, or the placement of a central venous catheter for chemotherapy administration. Yeah, very good. So what would that be? All right, so turning and looking to the risk factors of these patients, they really can be divided into 3 main categories with cancer-specific, patient-specific, and treatment-specific. The first one we'll talk about is patient-specific risk factors. And this really includes just looking at the patient as a whole. So do they have comorbid conditions such as AFib, or are they diabetic? Have they had a prior thrombosis before? So maybe do they have a gene mutation that that puts them at a prothrombotic risk? Performance status, again, are they ambulating? Are they eating? What is their performance status? And then also demographics, so are they older? What's their sex? What's their race? Again, all these factors can lead to a prothrombotic risk. And then talking about cancer specific, so the specific type of cancer that a patient has can place them at a higher risk versus others. I talked a little bit about the tissue factor and the expression in brain cancer and pancreatic cancer. So this study that I found looked at ambulatory cancer patients that had solid-state tumors, such as pancreatic, bladder cancers, et cetera, who were receiving active chemotherapy. And this study followed patients from the beginning of their chemotherapy administration to 12 months after they finished receiving chemotherapy. And what they were looking for was the occurrence of a VTE. And as you can see, pancreatic cancer had the highest rate of VTE at 19%, like colorectal at 10.6. All these were higher than their non-cancerous comparators in the control group, which was only a 1.4% development of a VTE. And those are the solid-state cancers as well. There's a lot of literature out there on hematologic malignancies. Some of the data that I found for lymphomas said that patients were at a 1.5 to a 13% risk, with leukemias anywhere from 2 to 20%. And then multiple myeloma was everywhere around 10% from what I saw. Another thing, too, is how advanced is their stage of cancer? Is it a stage 1 or stage 2? Some data that I found is that stage 1 and stage 2 patients are at a threefold risk, of developing a VTE, whereas a stage 4 cancer was anywhere up to a 17-fold risk of developing a VTE. Going back. And now treatment-specific risk factors. So for our ovarian and our breast cancer patients, a lot of times their hormonal therapies have been known to cause or place a patient at increased risk. Some data that I found on tamoxifen, which is a selective estrogen receptor modulator, was that patients that on active tamoxifen therapy was at a 5.5% increased risk of developing a VTE. And then some of the cytotoxic and neoplastics as well, specifically pig asparaginase, which is Oncaspar. This agent has a really interesting mechanism of action where it is a pegylated form of L-asparaginase, which then degrades amino acid asparagine into aspartic acid. It just so happens that antithrombin 3, which inhibits thrombin from working and therefore decreases the rate of clotting, keeps thrombin from working. Antithrombin 3 has very crucial amino acids of asparagine. So if you give this drug, it's going to degrade your antithrombin 3, therefore placing the patient at increased risk of having a clot. Cisplatin as well has been shown to place a patient at higher risk of developing a VTE. Erythropoiesis stimulating agents, they're controversial in cancer patients themselves, but then when you throw in the fact that they can also increase a patient risk of a thrombus, it even muddies the water a little bit more. For anti-angiogenic agents, these are becoming more and more popular in therapy. Bevacizumab, thalidomide, and lenalidomide. One study that I found with bevacizumab said that patients were at an increased risk by about 12%. So really just, again, all these agents, we're talking about the type of disease they have, and when you start treating them as well, you're just throwing more and more risk at these patients for developing a thrombus. And surgery, again, anytime you have damage to a vessel, you're just increasing the risk for a clot. So this brings us to question number 2. Which of the following is not a risk factor for cancer patients experiencing a VTE? Comorbid conditions, no history of a prior thrombosis, limited mobility, elderly age, or all the above. And you had a hint, so answer is B, yes. All right. So the standard treatment for VTE in patients with atom malignancy is pretty well defined as you usually start them on initial therapy with a low molecular weight heparin or unfractionated heparin, and then transition them to a long-term oral anticoagulation. And oral anticoagulation cancer patients is problematic. There's a lot of drug interactions with the agents that we're using to treat their cancers and also their supportive care agents. And so that just is another reason that we might try to stray away from them. But also then malnutrition. Is this patient able to eat well? A lot of these patients, they have their chemotherapy might have changed their sense of taste, and so they just don't want to eat. And also then you have chemo-induced vomiting, which, again, the patient would be less likely to want to take an oral medication. And if they do, they might end up just tossing it back up. And also there's this lack of clinical data in this patient population with the use of DOACs. So that's one thing that we'll delve into a lot in a little bit. There's 2 main guidelines that really drives the decision-making for these patients in the cancer world. The two main ones are the NCCN, so the National Comprehensive Cancer Network. I find these to be a little bit more just full of data. They're not really that helpful in making clinical decisions, whereas the ASCO guidelines tend to be a little bit more widely accepted in clinical use, and they really give some beneficial recommendations that I feel like most of our practitioners use when they are deciding on which type of agents to use to treat their patients' VTEs. Looking at the NCCN guidelines for the acute management of VTE, low molecular weight heparin is a preferred agent using either dalteparin 200 units per kilogram daily or enoxaparin 1 mg per kg sub-Q every 12 hours. This is the preferred agent. This is one that they definitely recommend over all the others. They also say that fondaparinux, unfractionated heparin are also acceptable secondary agents, but they do specifically state that direct oral anticoagulants are not recommended. For the chronic management or long-term treatment of a VTE, again, low molecular weight heparin is a category 1 preferred agent. This is for the first 6 months of treatment. They do talk a little bit in there about possibly switching them to an oral anticoagulant after 6 months, but that needs to be on a case-by-case basis. And then for warfarin, they say if you're going to use it, it needs to be initiated concurrently, just like any other patient that has a VTE. And again, they do say that DOACs are not recommended. So switching away from the NCCN guidelines and taking a closer look at the ASCO guidelines, for the treatment and secondary prophylaxis, they state that for low molecular weight heparin, it is the preferred agent over unfractionated heparin for the initial 5 to 10 days of anticoagulation. And then again, it is preferred over vitamin K antagonists for long-term anticoagulation, again, for the first 6 months. So I really want to look at some of the data behind this this recommendation as why are we saying we want to use this over unfractionated heparin? What data do they have to back up this recommendation? And so there was a Cochrane review that looked at, it was a post-hoc subgroup analysis of large randomized controlled trials. And overall, they included 11 studies and about 800 patients, which is pretty good considering a lot of our cancer studies and treatment have a lot fewer patients than that. However, only 3 studies reported the incidence of recurrent VTE, and really what they found was there was no difference behind low molecular weight heparin and unfractionated heparin, and the relative risk was 0.78, and you can see the confidence interval was pretty broad. And also, there was no data on bleeding outcomes in the cancer subgroups. So really what's driving this recommendation right now, there's nothing really significant at this point. But what is driving it is that there was a reduction in mortality with low molecular weight heparin compared to unfractionated heparin at the 3-month follow-up. And you can see that almost all the studies, all 11 of the studies did have a reduction in mortality except for 1. And when you do the pooled analysis overall, this was found to be significant at reducing mortality at 3 months. So now going back to the ASCO guidelines, for vitamin K antagonists, they state that it's an acceptable alternative for long-term anticoagulation if low molecular weight heparin is not available. If the patient's just either insurance issues, the patient just absolutely refuses to take low molecular weight heparin, they do say it's an acceptable alternative. And I'll quote the guidelines for the DOACs. They state that the use of novel oral anticoagulations for either prevention or treatment of VTE in patients with cancer is not recommended at this time. And then for their primary prophylaxis, they recommended that for patients, when they're inpatient, if they have additional risk factors, yes, absolutely, let's start anticoagulation on them, prophylaxis anticoagulation. And this may be considered for patients without additional risk factors, just again, taking the patient-by-patient approach. And for outpatient, one thing that differs from the NCCN guidelines and the ASCO guidelines is that the ASCO guidelines is they say routine prophylaxis for outpatients is not recommended. The NCCN guidelines don't even state whether they recommend it or not. They just give agents that they would recommend using if you are going to do so. And then for high-risk patients, low molecular weight heparin should be considered on a case-by-case basis. Again, low molecular weight heparin being the preferred agent. And they do say for multiple myeloma patients receiving thalidomide or lenalidomide, those anti-angiogenic medications we talked about earlier that cause an increased risk of VTE, they should either receive aspirin or low molecular weight heparin for prevention. All right, so I want to introduce patient PE. He's a 42-year-old white male with stage 2B testicular cancer whose status post 3 cycles of BEP, recently diagnosed with a left lower extremity DVT. PE has received anticoagulation with therapeutic low molecular weight heparin for the last 9 days while inpatient. He was dosed at 80 milligrams twice daily. PE is preparing to be discharged to home on enoxaparin. However, he is terrified of needles. He absolutely refuses to do the injections twice daily. The team looks to you to provide them with the most appropriate alternative. His past medical history is significant for the cancer and for hypertension. He's on very few home medications. Right now, it's just ondansetron 8 milligrams is needed for nausea and vomiting, and lisinopril 10 milligrams for his hypertension. His labs are fairly normal. His platelets are 109. He has decent renal function. So I introduced the patient. Now I want to look into some more information before we go to the question based upon this. But really start thinking about maybe what agent you would use as of right now, and then we look at some more data, see if that maybe changes your mind a little bit. So this is the Clot trial. This is the gold standard trial that really has driven our the guidelines and the data for why we use low molecular weight heparin in cancer patients. And this was released in 2003. in the New England Journal of Medicine. So when we talk about the Clot trial, this is really what is guiding all of our guidelines at this point in time. So it looked at low molecular weight heparin versus Coumadin for the prevention of recurrent VTE in patients with cancer. The authors recognized that these patients are at an increased risk of recurrent thrombosis despite the use of oral anticoagulation, so they're thinking maybe we need to do something that's not oral. Prior to the Clot trial, patients with malignancies were treated pretty much the same as every other patient who was at high risk for creating a clot or having a clot. And they really addressed the question of whether or not anticoagulation was less effective when given orally versus sub-Q for these patients. So this was patients with cancer and acute symptomatic VTE. Here, cancer was defined as either having cancer or treatment for the cancer within the last 6 months, or they have recurrent or metastatic disease. So they were treated for 6 months with either dalteparin 200 units per kilogram sub-Q for 5 to 7 days, then they transitioned them to warfarin, or they stayed on dalteparin 200 units per kilogram sub-Q for 1 month, and then the dose was reduced to 150 units per kilogram for the rest of the 6-month period. And the results for recurrent VTE, you can see that for the dalteparin group, 8% of the patients had recurrent VTE versus 16% in the warfarin group. This was found to be statistically significant. And that's pretty great when you think about a 50% reduction in recurrent VTE in these patients. If you look at the Kaplan-Meier curve, looking at the probability of recurrent VTEs on the left, and on the bottom we have the days after randomization, you can see that the effect was seen pretty quickly. The lines really separate out even less than 30 days. So overall, it looked like the low molecular weight heparin was definitely the go-to for these patients as far as recurrent VTE goes. We're looking at mortality. There really wasn't a difference seen between the two. 39% versus 41%, not much of a benefit seen as far as mortality goes. But still, with that pretty great response for the VTE, it's still something that was really impressive. As far as bleeding goes, for major bleeding, there was no difference between the group. Actually, more patients in the dalteparin group had major bleeding. But as far as any bleeding goes, it trended to be more beneficial with the dalteparin versus warfarin, 47 or 14% versus 19% overall. And this wasn't statistically significant, but it did trend towards benefit seen with dalteparin. So overall, it was concluded that the risk of recurrent VTE among patients with active cancer was lower when treated with dalteparin than when treated with warfarin anticoagulation. There was no significant reduction seen in major bleeding or in any bleeding, though it trended towards benefiting. There was benefit seen with dalteparin versus warfarin. So then about 12 years passed by before another trial came out that really looked at this. And so the next trial that was seen, this was released or published in 2015. This was called the CATCH trial. And this looked at tinzaparin versus warfarin for the treatment of acute VTE in patients with active cancer. Background again, these authors were really looking to see that a lot of their patients were still receiving warfarin, even though they knew that the guidelines really pushed for low molecular weight heparin. And so they wanted to see, okay, maybe we should look at this again to see was there really that big of an effect. And so this was patients included were, again, active cancer and acute VTE. Treatment was for 6 months with one of the following regimens, either tinzaparin 175 daily or tinzaparin and then transition to warfarin. And as far as the results go, for recurrent VTE, this study didn't really find a statistical significance. However, there was a benefit trending towards tinzaparin in this study group. So you can see on the Kaplan-Meier curve, again, there was benefit, and the lines did spread out, but unfortunately, that was statistically not significant. Mortality, again, there was no difference seen between the two groups. And bleeding, there was really no difference seen here either. Major bleeding was about the same in both groups. There was some benefit seen with these patients as well. But overall, the main benefit that was seen, even though there was no statistical significance, it did seem like they were trending towards that tinzaparin was better than warfarin for anticoagulation in cancer patients. There was no reduction in bleeding, but it was about the same in both groups. This takes us to question 3. So in the Clot trial comparing low molecular weight heparin to warfarin for the treatment of VTE in patients with malignancies, it was found that low molecular weight heparin expressed a benefit with statistical significance in which of the following endpoints? Overall mortality, major bleeding, clinically relevant bleeding, or symptomatic recurrent VTE. Yeah. D. All right, so DOAC or DOE. I'm going to switch gears and look now at the DOACs and maybe why these guidelines are saying not to use these agents, but yeah, we're seeing them being prescribed here for our cancer patients. So in phase 3 clinical trials, DOACs have shown to be non-inferior to standard treatment when compared to low molecular weight heparin and warfarin for treatment of DVT and PE, but this was in the general population. These haven't been directly studied in just our cancer patients. So like I said, no studies are available that have specifically addressed the efficacy and safety of DOACs in cancer-associated VTE. And those cancer patients were included in some of those trials. However, only about 5 to 10% of the study population were those with active cancers. So it's really hard to extrapolate the results of these studies onto the cancer patients. So I want to review a little bit about the DOACs. As you can see, the rivaroxaban, apixaban, and doxaban, anything that has an XA in it is a good hint that it's a 10A inhibitor. And then we have dabigatran, which is the direct thrombin inhibitor. So looking over the different DOACs, apixaban is dosed at 10 milligrams twice daily for 7 days, and the dose is dropped down to 5 milligrams daily. 5 milligrams PO twice daily. The half-life of apixaban is about 12 hours, so dosing it twice daily really matches up. It is one of the major metabolisms is through the CYP3A4 pathway, and it is a substrate for P-glycoprotein. Rivaroxaban, 15 milligrams twice daily for 3 weeks, and then 20 milligrams daily. Its half-life is 5 to 9 hours, so I'm not really sure how the once-daily dosing works, but again, its major metabolism is through the CYP3A4, and it is a P-glycoprotein substrate. All of our agents are P-glycoprotein substrates. Edoxaban is dosed 60 milligrams once daily for 5 to 10 days after initial parenteral therapy. Its half-life is about 10 to 14 hours. Again, CYP3A4 is a big one. And then for Pradaxa or dabigatran, it's dosed at 150 milligrams twice daily after 5 to 10 days of initial parenteral therapy. So again, that's half-life is about 12 to 17 hours, and it goes through conjugation pathway for metabolism. So I want to go through the different trials that really got these drugs onto the market. So look at the Amplify trial. This was looking at apixaban dosed the 10 milligrams twice daily for 7 days, followed by the 5 milligrams twice daily for 6 months. And it was versus therapeutic enoxaparin, followed by warfarin for 6 months. Active patients in this study, there's about 2.5% of the treatment group, so 66 patients and 77 in the warfarin group. And here, active cancer was defined as cancer or cancer treatment within 6 months or recurrent or metastatic disease. So this is the same type of definition that we saw with the Clot trial. And then VTE recurrence or VTE-related death, there was 2.3% in the apixaban arm versus 2.7% in the warfarin arm. Overall, was found to be non-inferior, and there was actually a benefit seen in major bleeding, only 0.6% in the apixaban versus 1.8% in the control arm. So that's one of the benefits seen with apixaban is that there is a benefit with less major bleeding. Now looking at the Einstein trial, this looked at rivaroxaban versus their therapeutic enoxaparin and warfarin. Active cancer patients, there was 6.8% in the treatment versus 5.2% in the control. And active cancer had the same definition here as it did in the Amplify trial and the Clot trial. For VTE recurrences, there was 2.1% in the treatment or in the rivaroxaban arm versus 3% in the warfarin. Again, this was found to be non-inferior. And there was no benefit seen with major bleeding or any bleeding with rivaroxaban. In the Recover trial, this was looking at dabigatran versus warfarin, and this was after they had received initial parenteral anticoagulation. There were about 64 patients with active cancer in the dabigatran arm versus 57 in the warfarin arm. And this cancer definition here was defined as cancer or cancer treatment within 5 years. or recurrent or metastatic disease. So there's some little bit difference there between the Amplify, Einstein, and the Clot trial. Here, again, it was found to be non-inferior as far as VTE recurrences or any sort of VTE-related death. And again, major bleeding was, there's no difference seen. All right, so the Hokusai trial, this was looking at edoxaban 60 milligrams daily or 30 milligrams daily based upon the patient's renal function, and versus warfarin. Here, there was actually quite a few more active cancer patients enrolled in this trial. Almost 10% in the edoxaban arm, so about 378, and then 393 in the warfarin arm. And here, it's kind of interesting because the definition of cancer was based upon the individual investigator, and they only enrolled patients if they were for sure not going to get low molecular weight heparin. So you can see that there's a really broad definition of active cancer in these trials. So overall, the recurrent VTE was found to be non-inferior to warfarin. And bleeding, so there was no difference seen with major bleeding. However, there was a statistical significance seen with clinically relevant non-major bleeding, and then any bleeding overall. So again, with the Amplify trial and in this trial, we saw that there was a benefit seen with less bleeding with the DOAC agent in the trial. And this just kind of I wanted to put this all in one table for more visual effect, but again, you can see that they're all non-inferior to warfarin, and there was benefit seen with major bleeding in Amplify. In the Hokusai trial, there was not a major benefit or major bleeding benefit, but there wasn't clinically relevant in any bleeding. And there was a meta-analysis that looked at these 4 trials and compared them all with the VTE recurrence. And you can see that the pooled random effects model showed that there was a benefit seen, with a lower risk with DOACs in the development of a recurrent VTE. And there's a few other single-center studies out there that have looked at the benefit with DOACs. Mayo Clinic, they had 118 cancer patients. They compared to 178 non-cancerous comparators, and patients were treated with either rivaroxaban, and these patients were treated with rivaroxaban, and followed for over 1 year. And you can see that the recurrent VTE, 4 versus 5 or 3 versus 2.8%, had a recurrent VTE. So really there's no difference between the two groups. And major bleeding, it was 2.5% versus 0% in the control group. So overall, I know it's a small study, but it's still interesting to see that there are institutions out there with the same question of, are DOACs safe to use in cancer patients? Kind of like our own institution. A couple years ago, there was a study completed by Amy Morris, Serbi, and Kathleen DeGregory that looked at the use of rivaroxaban in patients between 2012 and 2013, and wanted to look at the patients that were included were for VT prophylaxis, treatment, or reduction in the risk of recurrence. And they included 76 patients, and what they found was overall only 1 patient experienced a recurrent VTE, and 10 patients experienced bleeding. And when you compare these numbers to the Einstein trial, which really is the trial that got rivaroxaban approved and on the market, the numbers were about the same. So I thought it was really cool that we were at an institution who was looking at this before the data was even published. I think that's maybe why we see the use of apixaban and other DOACs in our cancer patients here. We were using them before the guidelines said not to, and we were seeing good results. So why change something that we're already doing and having good results with? And so one study that we're anxiously awaiting the results of is the Hokusai trial that's looking at specifically cancer patients. It's a prospective randomized controlled trial that has an estimated of 1,000 patients to be enrolled. This started in March of 2015 and looks to be ending in December of 2017, and includes patients that are 18 years or older with a confirmed acute DVT and PE and have a cancer diagnosis. I couldn't find a direct definition of how they're defining cancer, but that's one thing that I'll look forward to seeing in the end. And then their interventions are using edoxaban and dalteparin. The primary outcomes they're looking at is, again, the incidence of recurrent VTE at the end of the study period of 6 months, and the incidence of clinically relevant bleeding while on treatment. All right, so this goes back to patient PE. Based upon everything we just talked about, what would you recommend PE be prescribed? Edoxaban daily, rivaroxaban, warfarin with an INR goal of 2 to 3, apixaban, or despite PEs for needles, would you go counsel the patient and really push for him to be placed on enoxaparin daily, or sub-Q twice daily? Who would recommend warfarin? Who would push for enoxaparin? Who would put him on apixaban? Right. So I think the big thing is that I don't think any of these answers are wrong. I know the guidelines state that DOACs aren't recommended, but based upon the studies that we've seen here at UVA, at other institutions, I don't think that using DOACs is an issue in these patients. Warfarin is sure a good second, or I know it's the second option in the guidelines, and yet the first option would be the low molecular weight heparin. But you really just have to look at each individual patient. So is this a saddle PE, or are we treating a upper extremity DVT that was found by accident on scans? You really just have to look at it from an individual patient perspective and make the best decision for each patient. So I would have done PO twice daily. Sorry. All right, so the takeaway points. The processes leading to this prothrombotic state in our cancer patients is multifactorial. There's intrinsic and extrinsic factors leading to this. It's important to make a patient-specific recommendation every time, and low molecular weight heparin still remains a drug of choice for both treatment and secondary prophylaxis in cancer patients, and the results of that trial I talked about are being anxiously awaiting in the oncology world. Questions?